Hey guys, this is Jenna. I'm doing my case study 4.9 and it's on a factor V Leiden mutation. So basically, this case study is concerning coagulation disorders, and it's about a 25-year-old white woman who presents to the emergency department with a painful swollen right calf. She's been taking oral contraceptive pills for the last 6 months, and then on physical examination, the right calf is tender and 5 centimeters larger in diameter compared with the left calf. So upon further questioning, she states that her mother had had a similar problem with a swollen leg at a young age and had suddenly died of lung failure at age 45. Some other family members on the paternal side also had similar histories of swollen legs. So we'll dive into some articles and stuff and kind of work our way through this case study and explain what's going on here. I did pick this one because I found it kind of interesting. In the past year, I actually found out that I have factor V Leiden mutation. There's two different types. There's heterozygous and homozygous, and I'll explain that in a minute later. So this first article talks a little bit about thromboembolism and specifically DVT. It mentions that DVTs, as most of us know working in the hospitals, that they're about 100 times more likely in the hospital than in the general public. So automatically when this lady comes into the ER with a DVT, we're thinking a little bit more about what's going on, what could her possible risk factors be, which we'll see in here, and we'll talk about in the rest of the articles as well too. Every article mentions the risk factors, but she's using oral contraceptives, which will increase your risk for a DVT. But in conjunction with that, she also mentions her family history. She talks about her family on both sides having leg swelling, and that her one family member died from lung complications, which could have been because of a PE at some point. So we are automatically thinking there, because of that, there is some sort of family history of like a clotting disorder or something along those lines, which would lead a screening on this particular patient for factor V and other similar genetic things. So moving on, we'll talk a little bit more about what exactly is factor V Leiden mutation and some other treatments and testing for it. So factor V Leiden is present in about 5% of the Caucasian population. It's actually pretty common compared to most genetic disorders. It is really only seen in those of European descent. It's not really seen demographically in other populations. That being said, if those that are heterozygous for the factor V Leiden mutation have a 5 to 7-fold increase in thromboembolic events, and those that are homozygous, which is a little bit more rare, it's like 1 in 5,000 people, have a 50 to 100-fold increase of VTE, which could include DVT and PE. Although a lot of the articles on this talk about the fact that really those with factor V Leiden compared to other clotting disorders have an increased risk of DVT, but a lesser risk of PE in comparison. So that was just kind of an interesting fact that I found while I was reading. Exactly is going on genetically with this disorder. So basically, there's an enzyme called activated protein C, which anticoagulates blood when it inactivates clotting factors, which is factor V and factor VIII. Basically, what happens is there's a substitution of glutamine for arginine within this protein that causes the site where APC would normally cleave factor V to inactivate. So basically, when this site is inactivated, clotting is less inhibitive, meaning that it occurs faster. So basically, it creates what they call APC, or activated protein C resistance, and increases your chances of VTE. Now, there are other things other than just the factor V Leiden mutation that can cause APC resistance, because of the fact that that's one of 3 sites where APC normally cleaves. So there are other things that can cause this, which will also increase risk of DVTs and PEs. So this next article has a lot of the same information as the first one, but something I want to highlight in this article is risk factors for um, in conjunction with factor V Leiden that will increase your chance of DVT. So basically, if you have the factor V Leiden mutation, the heterozygous form anyways, you actually have a very low chance of having a DVT unless you have other risk factors. So the severity of the disease is proportional to the number of additional risk factors that you have present. Um, so in general, risk factors for DVT, even without factor V Leiden, but that will triple and quadruple your chances of having a DVT event are pregnancy, birth control, venous stasis, surgery, obesity, smoking, immobilization, cancer, and then other familial coagulopathies. So if you have another genetic type of thing or on top of it as well. So one of the biggest things that if you are aware of having this particular mutation that you do is you mitigate your risk factors. So obviously you don't smoke, you stay healthy, you don't stay inactive, you watch out and you're careful on things like long car rides or um, plane rides. But for the most part, usually just because you have this does not mean that you will have a VTE event and have a DVT or PE. The other thing that this article really highlights, which I mentioned before, it talks a bit about what they call the Leiden paradox, which is basically the fact that even though the factor V Leiden mutation results in greater chance of DVT, it has a lesser chance of pulmonary embolism that arise from those thrombi, and that is because um, for whatever reason, the factor V Leiden mutation usually causes DVT in the lower calf. And I think I even talked about this in my last case study, but most DVTs that actually turn to PEs are actually in the upper thigh. So calf DVTs are much less likely to become PEs, which are the most likely DVTs that are found in factor V Leiden. So that's just an interesting fact. Other than that, this article goes over a lot of the same um, things that we discussed in the first article. So lastly, we're going to talk a little bit about screening, treatment, and nursing implications based on the factor V Leiden mutation. So in this case study, this girl comes in, she has a DVT, so they're probably going to put her on heparin to treat that. And then they might start her on warfarin and wait till that's therapeutic before discontinuing the heparin. For her, since she has family history on both sides, and she's very young and she has had a VTE, I would say they'll encourage her to stop smoking because stop her oral contraceptives because that's a concurrent risk factor. But also, she might very well be a homozygous for this particular disorder, which means her risk of having another VTE on top of it or even a PE is very, very high. Um, so she will likely stay on therapy. For those that are heterozygous and have an event of DVT, they may or may not be on lifelong anticoagulants. That's kind of debated in the literature right now. As far as screening, they're absolutely at this point, she has family history and present symptoms. They're absolutely going to screen her for factor V Leiden as well as any other coagulopathies and probably try to rule out SLE for her and some other disorders that could have contributed to this. Um, However, in the general population, they do not screen people for factor V Leiden for reasons such as beginning oral contraceptive therapies, um, or surgeries or pregnancies. Um, and it's debated as far as whether or not you should actually screen people for factor V Leiden based on um, just family history if they don't have symptoms. I personally was screened for factor V Leiden. My sister was screened, my brother was screened, my dad was screened because my aunt um, had some surgery and developed a PE, and then they found out that she had it. Um, Found out my dad had it, and so it was recommended to us that we get screened too, just so that we're aware. But as far as for just being heterozygous, like we won't be on any medications or anything for it. We just have to be aware of risk factors, obviously. Um, so that's screening. Treatment as well. For I can say like for me personally, there my doctor initially kind of freaked out and um, wanted to put me on some medications and stuff to prevent DVT, and I basically said no because the literature really just doesn't support it. And I had done like a bit of research before going in, and my dad had also talked to a hematologist, so it was interesting. Um, but yeah, the risk factors for me are very small, so uh, it just was kind of funny that my doctor was like freaking out about it. I don't know if she didn't realize the difference between heterozygous and homozygous, or what, because I like mentioned that to her too, but she is not a hematologist, so can't really blame her too much there. As far as nursing implications, I would say that the article mentions as well that some of the most important things you can do as a nurse are proper screening. So if a family member says something about one of their previous family members, especially in the hospital when they're like post surgery and they're immobilized, or if they have a spinal injury, things like that in particular. If they say anything about, a family member having some sort of a clotting disorder, or having DVTs, or swelling in their calf, or dying from a PE, to do a proper screening and make sure the physicians are aware, to make sure that this patient in particular is definitely being anticoagulated, or has aggressive mobility protocol, or whatever it may be. I actually just the other night had a family member call me in the middle of the night and was like, I don't think he knows this, but I just talked to his mother, and he has a clotting disorder in his family. And lucky this guy was already on heparin. He was already on, some things there, and he hadn't had any issues with it. But I immediately asked, has he ever had any um, DVTs or anything, like any complications like that you know of? Um, what exactly happened with his family members? And so I gathered some information so I could let the physicians know. So they were sure to give him the proper um, care and preventative measures that he needed, in addition to just standard protocol. Luckily, he was kind of covered by standard protocol, and he actually was being anticoagulated, and he wasn't like a neuro patient that couldn't receive heparin. So he had his bases pretty covered there. But it was still very good to know, and we put it in the file and stuff to make sure that he had proper education on it as well, so that he could follow up outpatient with his primary care physician concerning it too.